Yeah, so good morning, everyone. So it's a fresh day, first day, and all the very best for your presentations. May I please invite Dr. Vanshika Khanna for her paper presentation, please? Yeah, welcome. Kindly introduce yourself first.
Time for the paper. Duration is 5 minutes, okay? 5 minutes.
Will they have the time? The IT team, would you have the timer, Buzz, at 5 minutes? Okay, good. Yeah, so please introduce yourself.
Versus lignocaine. As we know, pterygium is an elastotic degeneration of the subconjunctival tissue that affects the exposed bulbar conjunctiva nasally more than temporally, causing visual impairment when it encroaches the pupillary area. The gold standard for its treatment is surgical excision with conjunctival autograft. Though the long-term patient satisfaction following CAG is high, in the immediate postoperative period, the patient may experience considerable pain and discomfort at the surgical site once the anesthesia has worn off. Ocular pain is one of the most common postoperative complaints in these patients, causing discomfort. The cause behind this pain is the persistent inflammation post-surgery, which, if left untreated, may lead to recurrence. Thus, prompt control of ocular surface inflammation intra and postoperatively in pterygium surgery is an important determinant for reducing patient discomfort and subsequent recurrence. The aim of my study is to compare the effect of subconjunctival dexamethasone and lignocaine on conjunctival autograft harvesting in patients undergoing pterygium excision with CAG in their immediate postoperative period. This is a prospective interventional comparative study including 52 eyes of 52 patients who underwent the surgery for the same. All patients having primary nasal pterygium with grade 1 or 2 were included in the study. The exclusion criteria included patients who required general anesthesia, patients with recurrent pterygium, temporal pterygium, or a double-headed kissing pterygium. Patients having any other ocular pathology, ocular surgical history, or any bleeding disorder or systemic comorbidities. The patients were divided into two groups. Group A consisted of patients in whom CAG was harvested using 0.5 ml of 0.4% dexamethasone. Group B consisted of patients in whom 2% lignocaine was used for the same. All surgeries were performed by a single surgeon. After patch removal at 12 hours, patients were started on topical loteprednol, topical moxifloxacin, and a lubricant. The symptoms of pain, watering, and foreign body sensation were taken as a subjective measure of inflammation and were recorded 12 and 24 hours post-surgery. The objective signs of inflammation like conjunctival inflammation and lid edema were also recorded 12 and 24 hours post-surgery. The subjective signs were graded using the Likert scale that was included in the questionnaire, and the objective signs were graded on slit lamp examination. Observation and results. The mean age of Group A and Group B patients was about 47 and 46 years respectively. The male is to female ratio was 1.6 and 1.1 is to 1 in the two groups. The mean surgical time in both the groups was about 243 seconds and 258 seconds respectively. No statistical difference was noted between the two groups with respect to age, gender, grade of pterygium, and surgical time required. This has been shown in table 1. Postoperative pain, foreign body sensation, and watering was statistically significantly lower in Group A than in Group B at both 12 and 24 hours. Conjunctival inflammation was also statistically significantly lower in Group A at both the hours post-surgery. Lid edema, however, failed to show any significant difference with respect to severity in both the groups. One patient in group A and 2 patients in group B had graft displacement, which was repositioned under aseptic conditions. However, no statistical difference between the two groups was noted in this regard. This is the second table that shows the comparison of characteristics in the subjective inflammation, and table 3 shows the comparison among the objective signs.
1 minute.
This
more.
is a yes, ma'am.
Just a minute more.
Oh, yeah. This is a picture showing pre and post-operative images of pterygium excision using dexamethasone. And the second is using lignocaine. As we can see in the post-operative image, the conjunctival congestion and inflammation is more. Discussion. The main clinical considerations for patient satisfaction in the early post-operative period in those undergoing pterygium surgery are cosmesis and patient discomfort due to surgical trauma. The long-term satisfaction depends on recurrence of pterygium. Ocular pain, discomfort, and redness are the most common post-operative complaints of patients as a result of surgical trauma and ocular surface inflammation. Corticosteroids are well-known anti-inflammatory agents that can be used both topically and subconjunctivally to decrease perioperative inflammation. Take-home message. This study recommends the use of subconjunctival dexamethasone for graft harvesting in pterygium excision surgery with CAG due to its benefits in reducing ocular discomfort, inflammation, foreign body sensation, and ocular pain in the immediate post-op period, thereby enhancing post-operative ocular cosmesis and patient satisfaction. Thank you.
Yeah. Just a question for Dr. Vanshika.
Yes, ma'am.
Were your surgeries done under peribulbar block or under topical anesthesia?
No, ma'am, peribulbar block.
Peribulbar block. Okay. So there are a lot of other factors too which determine the
Exactly, ma'am.
outcomes and symptomatology after
Depends.
pterygium surgery. And did you attach the graft with glue or the
No,
sutures
we
were
left
used?
it with the blood clot.
Okay, so that is why the graft displacement.
Took place. There were 3 patients with graft displacement, and
Okay.
sutures were not taken.
So actually with such a small cohort, I believe that even 3 patients is a significant number.
It was high.
So I think, according to me, you should consider using either a glue or probably
Sutures.
just 2 sutures to attach 80 vehicle. I don't know what means.
Anyhow, you are giving post-operative steroids now. What is the role of intraoperative steroid use?
Intraoperatively, we were giving steroids. That is what we used, 0.5 ml dexamethasone to raise the bleb.
No, anyhow, we are starting post-operatively steroids. What is
Yes.
the rationale behind using intraoperative?
To further enhance the post-op inflammation, because the compliance with post-operative steroids is not in our hands. So we were just doing a study because earlier we were using normal saline for
For these
graft.
patients, you didn't use post-operative steroids?
No, we use post-operative steroids without bias in both the groups.
And what about bandage contact lens? Did you place?
No, ma'am, we did not use. It
So
was a
how-
tertiary center and BCL was not affordable. to
That
the
is the
patients.
main factor which prevents
Post-operative.
post-operative pain and redness, because if you have a bandage contact lens in place, the symptomatology, the symptoms are automatically
Less.
drastically reduced rather.
But that was not pocket-friendly
Okay,
for the patient.
thank you so much.
Thank you, ma'am.
The next presentation, effectiveness of AMT and SLET in alkali burn patients, a comprehensive analysis. Dr. Ankita Singh.
Yes, ma'am. Good morning, all of you. I'm Dr. Ankita. I'm presently working as assistant professor in IGMS, RIO, Patna. My fellowship is from Shankar Deva Nethralaya. This study which I am presenting is done in Shankar Deva Nethralaya during my fellowship period. So we are talking about effectiveness of AMT and SLET in different phases of alkali burn, a comprehensive analysis. I don't have any financial interest. Ocular burn is the common cause of corneal blindness as they may result in damage to limbal stem cells and cause limbal stem cell deficiency. There are various treatment approaches for acute and chronic phase. First is amniotic membrane transplantation or simple limbal epithelial transplantation. So the aim of my study was to study the surgical outcome of AMT and SLET in unilateral LSCD due to alkali burn. And the main thing about the study was this was the first study done in northeast part of the India. This is a retrospective interventional case study of 40 patients of unilateral alkali burn done at Sri Shankar Deva Netralaya Tertiary Care Center of Northeast India in duration of 2 years from clearance from ethical committee of the institute. The patients were divided into two groups, acute phase and chronic phase. In acute phase, the EMT was done, and in chronic phase, auto slit was done, and 20 patients were divided in both the group. This is a video showing placement of amniotic membrane transplantation, which was secured with the suture, and then VCL was placed, and pre-op and post-op analysis was done. So inclusion and exclusion criteria were, inclusion was more than grade 4 alkali burn according to Duer's classification, acute or chronic phase, and written informed consent. Exclusion were past history of limbal stem cell surgery, systemic disease associated with LSCD, entropion, ectropion, glaucoma infection, unwilling to participate. This is a video of SLED in which the fibrovascular tissue were excised and AMT was placed, and limbal stem cell from contralateral eye were taken and secured with glue and BCL. So the patients were followed up at 1 to 4 weeks and then 2 months, further 3 monthly, then till 1 year post-operatively. The medications used were systemic and topical steroid on tapering dose, cycloplegic, and tear substitute. Coming to result shows that there was a male predominance of 3:1 ratio, and the commonest age group involved were 31 to 40 years, and common site of injury was workplace, and causative agent were lime. If we talk about AMT group, 40% of the patient had epithelial defect that healed post-operatively, and mean time of reepithelialization was 3 weeks. This was the scoring criteria which was used to grade the patients in cases of SLED. If we talk about the visual acuity drastically improved from pre-operative to post-operative period in AMT and SLED, both the group, as we can see in table and graph. This is the result which shows in each patient of SLED, clinically, we graded the patient on basis of the clinical feature. If we see the graph, this is the pre-operative and post-operative. In post-operative symblepharon, after 1 year of the follow-up, 80% had grade 1 symblepharon and 20 had grade 2. If we talk about vascularization, 60% doesn't have any vascularization, 40% had grade 1. If we talk about conjunctivalization, 60% doesn't have and 40% has grade 1. And if we talk about corneal opacification, then 70% has clear cornea and 30% has grade 1.
50 seconds to go.
4 patients underwent surgery with focal recurrences with pannus extending to cornea. 2 patients underwent SLED, and 2 patients of SLED underwent DALC. Success rate was 72.8% in EMT and 78.6% in SLED. These are the pre-operative and post-operative pics of AMT. These are the pre-operative and post-operative pics of SLED at 1 year of follow-up. AMT is effective in promoting reepithelialization and reducing inflammation, thus preventing scarring sequelae in late stage. SLED is effective, safe and effective technique in treating LSCD. Corneal stroma and HAM can provide protection and nutrition for limbal stem cell without negatively influencing the clinical outcome. So to conclude, in a developing country like India, with limited facilities in the healthcare system, AMT and SLED are boon for the patient with LSCD, where laboratory facilities are not developed for cultivation of stem cells. These are my references. Thank you.
Just a question for you, Dr. Ankita.
Yes, ma'am.
I would like to know what was your criteria in selecting patients, whether you want to go for just an amniotic membrane or you want to combine SLED with the amniotic membrane. What was the criteria of choosing the patients?
Criteria for AMT group was acute phase, that the patient which are coming within 1 month from the mode of injury, within 1 month. That acute phase we did the AMT only, and in chronic phase, that is the patient of presentation after 3 months of injury, we took it under the SLED group, and only auto slits were included, not allo, in which both eye were involved.
And anything new you've added to the...
Ma'am, this is a well-known
Anything?
fact actually. Everyone is developing everywhere, but not in northern eastern part. It is not done in every center since it was a tertiary care center where
You could
this is
able
the
to...
only center where it has been done and no study has been reported. So we had done a retrospective study to compile and present the data that has been done.
nice results.
Thank you.
Yeah, and I would like to invite Dr. Shankara Shubhra.
Senka Subra Chaudhary.
He's going to present on surgical outcomes of a novel staphylomas repair technique using filamentous knitted polyester fabric.
Good morning, respected judges, moderators, and the delegates. I am Sankar Subra Chaudhary, here to present on our work the surgical outcomes of a novel staphyloma repair technique using the filamentous knitted polyester fabric. We have no financial interest. As we all know, that the sclera is the outermost covering of the eye and it provides a structural support to the eyeball. As a consequence of trauma or surgery or glaucoma or various immunological reaction, sometimes the sclera support is weakened and there is protrusion of the eyeball with an underlying uveal tissue known as a staphyloma. If a proper tectonic support is not given to the staphyloma in time, then over a period of time, it may lead to perforation, which may cause devastating sight-threatening complications. In our study, which is a 6-month study done in the Orbit and Oculoplastic Clinic of AIO, Kolkata, 4 cases were taken with a prospective interventional case study. The surgical technique we are showing that at first, meticulously the conjunctiva is dissected, as you can show, then the intercalary staphyloma is being exposed, and over it the filamentous knitted polyester fabric is placed with 80 polyglactic sutures. It is well anchored to the healthy sclera that is around it, and then over it the conjunctiva is secured with interrupted sutures. And you can again see the staphyloma is exposed, the fabric is placed, sutured with the healthy sclera, and then the conjunctiva is covered. Now all the 4 patients underwent successful repair. The IOP was well controlled with IOP lowering agents. None of the patients required a resuturing or a regrafting, and after 6 months of follow-up, there was no recurrence, hypersensitivity or rejection, and all the patients had a stable vision also. Now you can see the preoperative pictures with the intercalary staphyloma and the postoperative pictures after the application of the filamentous knitted polyester fabric. Irrespective of whatever the etiology may be, which causes staphyloma, there are various techniques that has been used for the tectonic covering with maybe autologous tissues like the periosteum, fascia lata, cartilage or cadaveric tissues, or commonly the synthetic materials like the goat tox. But the outcomes of all these materials are very variable, that is not predictable. There are incidents of graft rejection, dislocation, infection and necrosis. And sometimes there is also postoperative vision drop is noted. So here we are to advocate the use of filamentous knitted polyester fabric for a staphyloma repair technique because it is readily available, inert, toxic and cheap. It does not cause any immunological reactions, and we can also bypass the steps of the graft harvesting as it is needed for cadaveric tissues. And at 6 months follow-up, there was no recurrence of staphyloma or a repeat grafting is needed. The filamentous polyester, so the take-home message is the fabric have shown a great tensile strength and long-term durability. All the patients have expressed their satisfaction with their postoperative cosmetic, functional and structural outcomes. And the material is readily available, non-immunogenic, and shows a great promise as an alternative to donor sclera graft in staphyloma repair. Thank you.
Your follow-up is only 6 months. And
Doctor,
cases are only 4 cases, no?
We have done till now 4 cases.
you have done very few numbers, And have you done any comparison between the patch grafts, which homologous scleral patch grafts or any?
Yes, sir, we have done previously scleral patch graft because it is already been done, but for this study with the outcome, we have not done any comparison.
No comparison. And
all the
6
data we have, the
months-
meta-analysis data that are available.
6 months is a very short period to comment upon whether it's a successful graft or not. And how posterior have you been able to?
Posterior staphyloma?
Yeah.
No, sir, we have not included
You
posterior.
have only included anterior
anterior
staphyloma.
staphyloma, integrally staphyloma.
Okay. Thank you.
And what is the source of your material?
So actually, the material is already been used for years in cardiology CTVS department.
It's readily available.
It is hospital supply material. So they are actually using for the graft there is graft ectasia. They are using already the material. So we have taken the concept from them. Thank you.
Next one.
May I call the next speaker, Dr. Rushad Shara. This paper is on the Blink app, a novel artificial intelligence-based dry eye imaging and management modality.
Thank you. At the outset, I'd like to say that we don't have any financial disclosures related to this presentation. Now, the incidence of computer vision syndrome has been increasing, and we've seen in various countries, including India, the percentage is almost as high as 98% in some studies. Now, why is this important? Because we have a large number of patients coming to our clinic with pain, discomfort in the eyes, but their signs, if we see traditionally, the metrics are fairly normal. And the tear film metrics do not always explain these particular symptoms. Now, there are also studies talking about how blinks affect evaporative dry eye, and tasks that have increasing difficulty, they tend to blink less, they have more fatigue, and therefore this affects the evaporative dry eye level. So our research question was whether we can leverage technology at the population level to tackle computer vision syndrome and reduce the burden of evaporative dry eye. The purpose was to use this novel AI-based app and imaging modality to alter symptoms and tear metrics in subjects with evaporative dry eye and computer vision syndrome. So we looked at 44 eyes. We included patients with symptoms of computer vision syndrome, subjects with evaporative dry eye, and asymptomatic screen users. We excluded people with pre-existing ocular allergies, contact lens use, on any topical medication, inflammation, severe dry eyes, etc. We also looked at OSDI scoring, and the grading was done as per the normal. Statistical analysis was done by MedCalc. Normality of data was checked with the Shapiro-Wilk, and we used the Kruskal-Wallis test along with the ANOVA. All tests performed prior to the intervention and 2 months after intervention. We looked at the ocular surface imaging with the thermography device. We looked at Schirmer's, non-contact TBOT, tear meniscus height, and aberrometry in these patients. So this is our imaging modality called the thermography device. It's a handy thing. You can see it's attached kind of like an applanation mount, the gray box, which images the ocular surface. It gives you a thermal profile of the ocular surface, and it can capture in a restricted blink or in a continuous blink mode. It has a color scaling kind of like a pentacam, where the cooler colors are represented in blue, the warmer colors in red. And we looked at parameters like the severity, which is the score derived from the convexity and the compactness of the ocular surface thermal profile. We also looked at the ID app. This is a freely available app on the Android system which we have developed. This has blink reminders, so it tells you when to blink. You can set this as fixed reminders or smart blink reminders, where it actually looks at your blink pattern. If you're not blinking completely or blinking too slowly, it will actually remind you to blink. This is a video demonstrating the same. It can be installed on the PC as well. What you can see is you can have this icon which blinks when you're not blinking properly. There can be an audio which is turned on and off, so you don't necessarily have to look at that icon. And this blink reminds you to blink at the correct moment in time. It also has a 20-20 rule built in, which tells you to take a break every 20 minutes for 20 seconds and look at a distant object. So coming to our results, when we looked at the blink kinematics, we saw that the blink rate, the blink duration, the interblink interval, the partial blink percentage, and the thermography severity scores all showed improvement. although the partial blink percentage was the only one which reached statistical significance. In terms of the traditional tear metrics, the Shermers did not show any significant change. The non-contact TBUT, the lipid layer thickness, the spherical aberrations, the corneal higher order aberrations, the tear meniscus height, and the OSDI were all significantly better in post-intervention eyes. Now, we also tried to look at how the OSDI changed after the intervention, and what this graph essentially is saying is that patients with mild and moderate OSDI scores shifted towards the normal OSDI scores after the intervention. You can see the percentage of normals has gone up, the mild and moderate have gone down, so it does help in mild and moderate conditions, severe not so much. Future directions is to use this. It also gives you information of how to do warm compression, lid hygiene, etc. It has a visual acuity test built in, and to integrate all this as a composite solution. So the limitation of our study was it was a small sample size, shorter follow-up duration, and the app is not available on the iPhone. What was known is that computer vision syndrome is a growing public health issue. Our study adds that ensuring blink hygiene, improving objective and tear metrics without pharmacological intervention can be done with this. As the app is available on smartphone as well as desktop, it can prevent development of more severe dry eye and help reduce severity of evaporative dry eye. Thank you.
It's an excellent app, Dr. Rushad, that you've developed. Just that the sample size, I believe it's too small to actually extrapolate it to a larger population, but I'm sure it's going to help, and it is the upcoming thing in the future. Would you like to add?
Yes.
Is this app chargeable or?
No, it's free. It's
Free of
freely
cost.
available on Android. You can go to Play Store and
What's the
download
name of the app?
ID, EYED.
D.
D. And so I think I can. Okay, the presentation on EYE and D. It's
Okay.
ID basically.
Okay. So this has to be downloaded, and it is there on your phone.
So you can keep it on the phone. It can, even if you've not got the screen on, it will give you an auditory reminder to blink. You have to just enable the thing on the phone. Once you've downloaded it, you can switch it on, and
Okay.
it will continue to tell you. You can also switch it off. It will continue to play over your other apps and other things that you're using on the phone. So it doesn't have to be on specifically. It can continue to run even if you're doing something else on your phone or on your device. And you also have the desktop version of it, which would also be
Also from the Google Play Store,
yeah, it can be downloaded on.
but not available on Apple.
No, not available on Apple right now at least.
Thank you. Nice
Okay.
presentation.
Thank you.
Dr. Mahati is there?
So I think she's having another session, so we would like to invite her for her talk, which is Andhra Pradesh State Ophthalmological Society, talk on role of skin prick test in allergic eye diseases.
Good morning, everyone. Thank you so much for giving me this opportunity. Today I'll be talking about the role of skin prick test in allergic eye diseases, still an ignored practice in India. We all know the complications of allergic eye disease, be the disease proper causing the complications, or the mechanical factors, or the treatment we use. And there are a variety of consensus which give us about the protocols to follow the treatment of allergic eye disease. And in all of them, the first step is identification of the allergen and avoiding the allergen. But are we really doing it? So why to identify and how to identify? Why to identify? Prevention is better than cure. So avoid the allergen, half of the problem is taken care of. And counseling the patient is very important. based on the type of allergen. And also there is immunotherapy available, which is low dose allergen orally in the form of drops, which is given over 3 to 5 years, where there is a slow desensitization for that particular allergen, and it cures not only the ocular symptoms but also the systemic symptoms. So how to identify? There are a variety of tests, of which skin prick test is the most simple and sensitive and specific to about 90%. When we searched for studies, we found about 16 global studies with 1,173 patients, but we couldn't find any Indian studies. So our aim is to identify the common allergens causing allergic eye diseases and to study the demographics. We did a prospective study from March 2023 onwards with a sample size of 59 patients in children attending pediatric ophthalmology and squint clinic in our hospital. We included VKC of all grades, and in children who are symptomatic for more than 6 months, aged between 3 to 20 years, and excluded any symptomatic patients of less than 6 months. When a child comes to us, be it a new or old, under diagnosis, a proper history is taken and an inquiry into family history and systemic symptoms is also made, and a diagnosis of acute or chronic VKC is made. If the symptoms are less than 6 months, the child is treated, but if more than 6 months, if it's acute, the child is treated, and if it's chronic or in resolving, all the steroids and immunomodulators, antihistamines are stopped for 15 days, and then the skin prick test was done by an allergy specialist. The panel of allergens used range from dust mite, cockroach to the commonly available plants. The skin prick test was done by injecting the allergen to the forearm or upper back, and positive is more than 5 mm of induration compared with histamine or saline control. Coming to the results, males were 3 times more commonly affected than females, and the most common age group was between 3 to 10 years, which also followed the gender distribution. Positive skin prick test was seen in 76% of the children. And among the positive people, systemic features were more prevalent. And sneezing was the most common systemic association. And among the allergens, dust mite and cockroach were the most common allergens, followed by plant allergens like Ricinus, Parthenium, Cassia, and sometimes even a dog and cat too. And 1/3 of the patients showed at least more than one allergen positive skin prick test, and females showed a higher positivity rate for plant allergens. And cockroach was seen more prevalent than dust mite in the older age group. In India, dust mite is still the most common allergen, followed by cockroach. And compared to the previous studies, most of the studies had a 70% positivity rate, and males were more than females, which was also almost same in our study. And house dust mite was the most common allergen, except in Spain, where it was pollen. So to recommend, when a child comes to you for allergic conjunctivitis, always ask for systemic symptoms. And early morning sneezing is an important symptom to implement dust mite and cockroach control strategies. Try to identify the allergen involving an allergy specialist, and counsel the children and parents for allergens avoidance strategies, and if possible, and if affordable, refer the child for immunotherapy. Few control strategies. The pitfalls being the commercial preparations which are being tested contain only few concentrated proteins, and negative tests are not always negative. And affordability of the test and immunotherapy are a bit on the costlier side. These are my references. Thank you.
What is the percentage you related to eye allergy and systemic allergy? What is the percentage you found in relation to systemic allergy and eye allergy?
Around 60 to 70% of the patients with among ocular allergy, around 60 to 70% of them had systemic features also. Okay. And if it's a had systemic features, the skin prick positivity rate was very high.
What was the general cost for the whole test which you used to
The test
send?
costs around 2,500, But the immunotherapy is costly. It has to be for over 3 to 5 years, and for every 3 months, it's 8,000 rupees.
Any relation to food?
We didn't find in our
Have you tested for
ILH.
any relation
There
to
was,
food?
we tested, but in our study, we didn't get any relation to food. We got mostly for cockroach, dust mite, and plants.
So did this change your management of these patients?
Yes, ma'am, very much. Because who are all affordable, we started them on immunotherapy, and there was a good relief of symptoms. And we have few extreme children who had gone to keratoconus with vision loss, and still they were rubbing their eyes, they had ocular allergy, they had systemic allergy, but once they were started on immunotherapy, all the symptoms came down. So at least the progression of the disease had stopped.
So what was the exact immunotherapy
Madam?
What was the exact immunotherapy
Immunotherapy
regime
is,
that
it
you-
comes in a customized bottle, customized vials. According to that particular patient, it has to be maintained in a cold chain. It will be delivered to your house. It is usually taken care by the allergy specialist. They give the low dose allergen. If the child is positive for dust mite, it is that dust mite allergen where there is a desensitization for over 3 to 5 years. It will be in the low dose.
So it's a systemic therapy.
Yes, ma'am. It's oral drops, oral sublingual drops. Mornings, half an hour before, half an hour after, the child should not eat anything.
And where did you get this allergy test done and the specialist? Any particular preference for that?
Usually they are available, ma'am. Now usually a pediatrician, dermatologist, ENT or a physician. Usually these are the 4 people who can do that course and they can do the test.
So with the number of allergens we have in our country, it is very difficult to pinpoint what is the commonest cause of allergy in these cases. And many times, though we have pointed out one of it, it could be recurring because of some other cause.
Sir,
So with that, do you think this immunotherapy which you are giving will be kind of a blanket for all other allergens as well?
Sir, actually this study is going on in the second part, and we are trying to study the features of the children who had multiple allergens positive, but immunotherapy is not available for all of them.
All of them,
It's
right?
only available for dust mite as of now in India. But even with dust mite treatment, their symptoms have, if the child had positive for dust mite and a small positive value for cockroach also, the child was responding for the dust mite immunotherapy.
Okay, that's great. Thank you.
Thank you, sir. Thank you, ma'am.
So now I would like to invite Dr. Suranjini G for the paper presentation. Sugaranjini, I'm sorry.
Good morning. At the outset, I would like to thank everyone for giving me this opportunity. My paper is titled Looking Beyond the Schirmer Strip in Seronegative Sjogren's Syndrome. So according to the EULA criteria, a score of more than 4 is required to classify a patient as Sjogren's, with the maximum weightage being given to salivary gland biopsy and an anti-Ro antibody positivity. But 30% of these patients are negative for anti-Ro antibodies, and in them only a salivary gland biopsy, which is an invasive method, is the crucial for diagnosis of Sjogren's. So as ophthalmologists, can we find a non-invasive method to diagnose the Sjogren's syndrome? That was our aim, to assess the diagnostic ability of fluorescence-assisted examination of the lacrimal and the labial salivary gland in detecting Sjogren's syndrome amongst the seronegative suspects. So this was a prospective observational study in which all patients suspected to have clinically Sjogren's syndrome and who were anti-Ro antibody negative were referred from a rheumatology center for an ocular examination. The ophthalmologist was blinded at this point, and post the ophthalmic examination, patient was sent back to the rheumatologist for a salivary gland biopsy, and based on the salivary gland biopsy, the patient was determined as Sjogren's syndrome or negative Sjogren's. These were the ophthalmic examination parameters that we did. Apart from the normal dry eye parameters, we also looked at the lacrimal gland for the number of tear secreting points and the speed of the dilution of the dye by the tears, and also the number of salivary secreting points. Coming to our results, 59 patients suspected to have Sjogren's underwent a salivary gland biopsy, which confirmed the disease in 11, and 48 of them were negative. What 48 of them were negative. All these patients were age matched and more than 90% were females. And coming to the symptomatology, between the two groups, as we can see, majority of them did complain of dry eye and dry mouth. But, though the mean OSDI was higher in the biopsy positive, there was no statistical difference. Same was true for the tear film height, where less than 0.22 is indicative of the disease. There was no significant difference. And in Schirmer's test, where less than 5 is indicative of disease, there was no statistical significant difference between the two groups. Coming to the ocular surface staining score, where more than 5 is an indicative of the disease, there was no significant difference. And in the tear secreting points of the lacrimal gland, where the mean secreting points were 2.5 in the entire sample size, a decrease tear secreting points was not noted significantly different between the two groups. The only significant difference was the tear dilution speed, where the biopsy positive patients had a slow tear outflow rate compared to the biopsy negative patients. Coming to the labial salivary secreting points, where 14 was the mean, a decreased secreting points was not statistically significant between the two groups. So in our study, among the determinants of positive biopsy result, a slow tear flow rate showed a positive correlation with salivary gland biopsy positivity. Coming to the discussion, Kim et al. Pioneered the direct visualization of tear outflow from the lacrimal gland, and they brought about the quantification of tear secretion, and they noted a reduction in the tear secretion rate. This was further studied in detail by Singh et al. But they used a cumbersome methodology where they actually videotaped the entire salivary gland, lacrimal gland outflow, and they used a software to figure out the tear outflow rate. But this is a very cumbersome methodology which cannot be reproduced. So we adopted the rapid and slow tear secretion classification for reproducibility in clinical setting. Though this has been studied extensively, the correlation of this tear outflow rate with salivary gland biopsy is still lacking in literature. In the labial minor salivary gland secretion, in our cohort, we didn't see a significant difference between the two groups, and they were reduced in both the groups. And this could be because that the individuals were age matched, and this could be an age-related decline. So in our study of seronegative Sjogren suspects, only the tear outflow rate was a positive determinant, and a slow tear outflow was most significant predictor of salivary gland biopsy. So the limitation of our study is a single center, small sample size, and the tears and saliva flow rate was not quantified. And in conclusion, a slow tear flow rate detected through fluorescence-assisted direct evaluation of lacrimal gland in Sjogren's syndrome suspects with a seronegative status should prompt a salivary gland biopsy to confirm the diagnosis of Sjogren's syndrome. Thank you so much for your patient listening.
Yeah, so I just want to ask you one question. Did it have any significant or a bearing in your management, the difference between the tear flow rate between the seronegative and seropositive?
Ma'am, we didn't take part in the treatment aspect of this. This was only for the study purpose. We only evaluated the patients. As a protocol, we just prescribed them tear substitutes. So for this particular study, we did not take part in the treatment aspect of the patient. So we just studied.
Basically, most of the parameters, as you said, are similar.
Similar.
And there is no practical difference in the symptomatology and management.
Correct.
Thank you.
So what was the sample size which you had taken?
Ma'am, 59 were seronegative suspects. They were clinically suspected to have Sjogren's syndrome by the rheumatologist. And then they underwent salivary gland biopsy, out of which 11 of them were positive through salivary gland biopsy.
All right. So for salivary gland biopsy, you were sending them to the ENT department?
No, ma'am. The rheumatologists were performing it themselves, yes.
All right.
So we only did the ocular examination in a blinded way. We were not aware whether they were positive or negative. Only after our evaluation, they went back for the salivary gland biopsy.
I think that's all.
Yeah, thank you. Thank you.
Thank you.
Yeah, I would like to invite the next speaker, please, Dr. Poonam Singh. Dr. Poonam Singh is there. Dr. Divya Srivastava.
Please, the slide with my name on it. The slide with my name on it, the presentation with my name on it. Dr. Divya Srivastava, the presentation. Okay. Second. Good morning, everyone. I'll be presenting on the topic, topical anti-inflammatory versus artificial tears in dry eye, long-term efficacy and side effects. So dry eye is a very common ailment with a prevalence of around 20 to 50% in Southeast Asian countries like ours. This makes it important to understand the role of ocular inflammation in its pathophysiology, wherein a vicious circle is created by tear film instability and the activation of inflammatory pathway. This warrants the use of topical anti-inflammatory drugs to curb the inflammation and not just topical lubricants, which replenish the tear film only temporarily. Earlier, the topical anti-inflammatory were used only in severe dry eye disease, but various studies in the recent past have started evaluating their use in mild to moderate dry disease as well. But a very few studies have compared the topical anti-inflammatory with the lubricating drugs. So the aim of our study was to compare the efficacy and safety of topical chloroquine phosphate 0.03%, topical cyclosporin A 0.05%, and topical sodium hyaluronate 0.18% in mild to moderate dry disease. Two of these drugs are topical anti-inflammatory and one is a lubricating. These are the objectives: to assess the demographic parameters of a subset of population in North India with mild to moderate dry disease, to assess a correlation of digital screen time with the prevalence of dry disease, to assess and compare the change in various dry disease parameters with the use of these three drugs, and also to assess their safety profile. It was a prospective comparative study which enrolled 105 patients aged 18 to 75 years with mild to moderate dry disease, presenting to the outpatient department of AIOS PGIMS Rohtak. Ethical clearance was obtained and the study was conducted for a period of 1 year. Patients presenting with various dry disease symptoms were subjected to a battery of tests, which included the Ocular Surface Disease Index score, tear film breakup time, Schirmer's test, and corneal fluorescein staining. Patients with only mild to moderate dry disease were included in the study, and any patient having a previous history of ocular surgery or trauma in the last 6 months or any ongoing current ocular disease, patients having known hypersensitivity to the drugs in study, patients with uncontrolled systemic disease, pregnant women and lactating women, these were excluded from our study. Patients were divided into 3 groups, and group 1 was started on topical chloroquine phosphate 0.03% twice a day, group 2 on topical cyclosporin A 0.05% twice a day, and group 3 on topical sodium hyaluronate 0.18% 4 times a day. The patients were followed up at 1 week, 1 month, and 3 months, and the battery of tests were repeated at every follow-up visit. SPSS version 26 was used, and the level of significance was set at p-value less than equal to 0.05. These were the observations. The mean age in group 1 was around 35 years, group 2 39 years, and group 3 34 years. The maximum number of patients in our study were in the age group of 25 to 50 years. Amongst the affected individuals, females were slightly more than males in our study. This study also recorded the digital screen time of all the patients, and it was found that maximum patients had a screen time of more than 6 hours, followed by 3 to 6 hours. The patients in our study presented with a variety of symptoms, but the most common symptom noted were gritty or burning sensation, light sensitivity, and difficulty in screen work or TV watching. These were our observations. TBOT of right eye, left eye, Schirmer's results. Corneal fluorescein staining test was negative for all our patients at the baseline and every follow-up visit, so it did not give us any inference. And these are the side effect profile. So our results were, on comparing the OSDI score of all the 3 groups at baseline, there was no statistically significant difference, but at 3 months, the OSDI had a significant difference between group 1 and group 3, which was chloroquine phosphate and sodium hyaluronate, and group 2 and group 3, which was cyclosporin A and sodium hyaluronate, whereas no difference was noted between group 1 and group 2. Similarly, for the tear film breakup time test, baseline had no difference, but at 3 months, the OSDI score between 1 and 3 and group 2 and 3 had a statistically significant difference, whereas no difference was noted between group 1 and 2. Comparison of Schirmer's test of all the 3 groups at baseline and at all the follow-up visits did not give us any statistically significant difference for any of the drugs. And the side effect profile at the end of 3 months was noted to be only mild irritation for 5.7% patient in group 1 and 2.9% patient in group 2 in our study, and none of the patient in group 3. And majority patients, 97.1%, had no side effects noted for the period of 3 months that we tested. So we concluded that topical anti-inflammatory drugs like topical chloroquine phosphate 0.03%, cyclosporin A 0.05 have a significant benefit in the management of mild to moderate dry disease, which was noted by improvement in the subjective tests like OSDI score as well as the objective tests like tear film breakup time. However, when we compared the topical chloroquine phosphate and topical cyclosporin A, no significant difference was noted. This study also noted that no significant side effects are there with the use of any of the drugs in majority of our patients. Hence, topical cyclosporin A and chloroquine phosphate are efficient and safe management options in patients of mild to moderate dry disease, and these in combination with topical lubricating drugs can give early and better symptomatic improvement. And as ophthalmologists, we should start prescribing these drugs in mild to moderate patients, which form a majority of our subset of patients in our OPD. Limitations were a relatively small sample size, the fact that study was conducted in a single center, and diagnostic protocols employed were limited due to availability. There were no financial supports or conflicts of interest in my study. Thank you so much.
So what was the criteria for you to allocate these patients into the 3 groups?
Ma'am, we randomly allocated the patient, systemically allocated the patient into 3 groups. As the patients were coming in the OPD, systemically the patients were allocated, one in group 1, then group 2 and group 3.
So what is the difference when you say mild or moderate dry eyes? You know, because one of your drugs is taking care, like sodium hyaluronate is taking care of the symptoms, while the other 2 are taking care of the pathogenesis. So first, the mechanism of action is completely different, and mostly the anti-inflammatories are added to the tear substitutes. So how did you kind of compare and came to this conclusion that you mean to, from your study, if we go, any patient coming with mild dry eye disease should be started on cyclosporin A instead of any regular tear substitutes?
Ma'am, we tried to compare this fact only, that there has never been a comparison between using only topical lubricating and using these drugs adjuvant to that also. We can use adjuvant, but we tried using it
primarily.
Just to compare, so that we are not using a lubricating, still we are getting benefit in dry eye disease patients in mild and moderate cases both. So we did not add a lubricant or adjuvant to this drug to compare it.
Do we have specific chloroquine topical preparations?
Yes, sir. Chloroquine phosphate is available in 0.03% topical.
Separately?
Yes, sir, in the market.
So, but in your study, if a patient with mild dry eye disease, we start on cyclosporin directly or we start on sodium hyaluronate, he's going to respond to either.
Yes,
so why should we ask the patient to pay 10 times the amount for a mild dry eye disease, which could be tackled with a simple tear substitute? Because the results, according to your sample size, is more or less the same. So that is what my question is.
Ma'am, because right now also we have been following up the same patients, so we have observed that patients who we started on the anti-inflammatory therapy, at the end of 3 months, there was significant reduction in both signs and symptoms in comparison to the lubricating drugs. Lubricating drugs, mostly we have to give more chronic than the topical anti-inflammatory. So they...
Why chloroquine? Any immunological reason?
Ma'am?
Why chloroquine? Why eye drops? Any immunological reason is there?
Ma'am, it's an anti-inflammatory, topical anti-inflammatory
What she wants to ask is, did you categorize the patients whether any of them had Sjogren's or history of rheumatoid arthritis or keratoconjunctivitis?
Actually, any systemic or uncontrolled systemic disease were in our exclusion criteria, so only mild to moderate disease patients were included. We excluded those patients.
Thank you.
Dr. Nikita Shah? Not there? Dr. Jitendra?
This one, Divya Srivastava.
Thank you.
Good morning, everyone. So I'm Dr. Jitendra. I'm working as assistant professor in PGIMS Chandigarh. So I will present my free paper on age-stratified analysis of ocular cicatricial pemphigoid. So as we know that OCP is an autoimmune disorder which is quite rare, but it is characterized by progressive inflammation and scarring of conjunctiva, which lead to severe ocular surface disease and irreversible vision loss. So literature review suggests that clinical presentation of OCP varies widely, may be influenced by factors such as age, gender, race, systemic involvement, and coexisting autoimmune conditions. So we try to find out any difference in disease behavior and management strategies between the 2 age groups, and thus this study seeks to contribute to a personalized approach to care of these patients. So objective was to study demography, clinical features, diagnostic and management strategies in younger, less than 15 years of age, versus an older, more than 15 years of age of patients of OCP at the time of presentation. So it was conducted as a tertiary eye care institution in North India. So medical records were analyzed between the period of August 2019 and July 2024 after taking ethical approval from the institute. The patients were categorized as I have described. The two groups were compared in terms of age, gender, visual acuity, disease, clinical severity score, staging of the disease, complications, and management strategies. Appropriate statistical tests were utilized. So coming to the results, total 43 patients were included in the study. 17 patients of 34 eyes were in group 1 and 26 patients with 52 eyes were analyzed in group 2. So mean age at presentation was 25 years in group 1 and around 65 years in group 2. P-value was significant for the age difference. Duration of symptoms before the diagnosis was similar between the two groups. There was no statistically significant difference. On an average, it was 53 for the group 1 and 55 months for the group 2. So gender distribution was different in both age groups. Younger groups had more male patients as compared to the older groups in which female preponderance was noted. The diagnostic test, the direct immunofluorescence, which is used to diagnose the OCP, was noted significantly higher positivity rate in the younger group as compared to the older group. Visual acuity at presentation was significantly worse in the older group. This suggests that older patients present with more visual acuity impairment because of advanced ocular surface changes at the time of diagnosis. The mean Foster state as a presentation was higher in older group. This implies that at the time of presentation, the disease was already progressed in the older group. The patient in younger group presented the unilateral findings, and in all these patients, the OCP were diagnosed later in the other eye also. So this suggests a higher index of suspicion in younger patients is important to diagnose OCP. The conjunctival clinical activity score was higher in group 1, but it was not statistically significant. Multi-system involvement was noted more commonly in the younger group. Oral mucosa was involved most commonly. However, the genital mucosa were involvement in the younger patients. Patients with coexistent disease like rheumatoid arthritis, Sjogren's syndrome, TB were more commonly noted in the older group, which highlights the higher burden of these autoimmune disease in older patients. Choice of immunosuppressive therapy differed in two groups. While the younger group was treated mostly with the azathioprine or mycophenolate mofetil, and cyclophosphamide was utilized more commonly in the older group. However, rituximab was used as a second-line treatment in both the groups. Corneal involvement was noted similarly across the groups, and the need of the surgery like amniotic membrane, eyelid surgery, corneal perforation surgery, cataract surgery was noted comparable in the both the groups. So this is the summary of all the findings. And this study has some important implication on the management of OCP. The higher stage of the disease at the time of presentation in the older group underscores the need of the early diagnosis and management in this population. For the younger patients, the rate of biopsy positivity is higher, so disease can be picked up and treated confidently in the younger group. Comparable rate of complications between the two groups such that the age alone should not be dictate treatment intensity. Instead, management strategies should be tailored to the individual patient, taking into account the disease severity, comorbidities, and treatment outcome. This study has few limitations, like it was a single center-based study, and it was retrospective design and relatively smaller sample size, which may induce bias and limit the generalizability of the findings. So conclude, this study highlights the need of age-specific approaches to the diagnosis and treatment of OCP, with an emphasis on the higher suspicion, early biopsy, early medical intervention, and individualized therapy. By addressing the unique challenges in different age groups, clinicians can optimize outcomes and improve the quality of life for the patient with this debilitating condition. These are my references. Thank you.
I would like to congratulate you for conducting this very nice study. So finally, your carry-home message will be?
The carry-home message is that if a patient presents with the features of cicatricial conjunctivitis in the younger age group, which is generally ignored, we should have a lower threshold to send the biopsy, because biopsy positivity rate is much higher in the younger group. If we have a positive biopsy reports with us, we are confident in treating the patients, which are generally ignored in the younger age. And for older patients, again, literature suggests that most of the patients present in the older age group, but their biopsy positivity rate goes down because of the scarring of the conjunctiva. So in those patients, we should try to develop some mechanisms to detect them at early stage so that the ocular surface changes doesn't progress much.
So what were your initial signs or symptoms, especially in young patients, whether to send the biopsy or not?
So basically, we follow a protocol in which we have used sclerosing conjunctivitis score developed by Basu and Sanbhag et al. So we say that if we have a set of signs and symptoms and clinical findings, and if the score is more than 5, we exclude a most common diagnosis called Stevens-Johnson syndrome. So for rest of the patients which have score less than 5, we send the conjunctival biopsy, oral mucosal biopsy, and if any of them comes positive, we diagnose and label them as biopsy proven OCP. Although there are so many other differential diagnoses of this condition, but we try to rule out them on the basis of clinical history and examination.
Are these patients not associated with atopy or type 1, type 2 hypersensitivity?
No, sir. Actually, these diseases have altogether different pathogenesis than allergic eye conditions. It is a disease which is a part of mucous membrane pemphigoid, which we see in the dermatological conditions.
So it's a type 2 hypersensitivity reaction where
Antigen antibody complex deposited at the basement
deposited
membrane.
at the
Yeah, type 2 you can say.
What is the youngest stage you identified?
Actually, we have, in this study, it was 13-year-old, but now we have a patient who's 8-year-old also, which is being followed mainly in the dermatology department, but he has very slight early.
Any family history in those patients?
No, mostly these patients don't have any family history. So etiology is not clear for this disease, but a lot of research need to be done to find out.
Treatment in all these patients for biopsy positive?
Yeah, actually, ma'am, the treatment is, tailorized as per the need of the patient. If there is a lot of inflammation in the conjunctiva and we think that it is going to worsen the, ocular surface disease, so we have to start immunosuppressive therapy. But since the patients are young, so we have to think in that we also like that the treatment itself may lead to a lot of other problems. So as per requirement of the ocular inflammation, we start the treatment.
So you have to do it with the immunologist always?
We are doing, ma'am, with the teamwork, like dermatologist and immunologist are involved.
And one more question, these patients, most commonly, how do they present to your OPD? These youngsters, with what symptoms do they come?
Actually, they present with lot of conjunctival inflammation. Sometimes they present with non-healing recurrent corneal epithelial defects, sometimes superadded infection. And these all patients have some kind of cicatrizing changes in the lower fornix and tarsal, fibrotic. If you ever the upper eyelid, you see a lot of tarsal scarring. And sometimes they have dry eyes also. It is believed that OCP lead to dry eyes in the later stages, but our findings are, we noted some different presentation. They have early dry eye also, because lacrimal gland area has gotten scarred earlier in the disease, then they have very low tear production. Like somebody has shown DATS, dynamic assessment tear excretion. So we do that also. We see that they don't secrete much tear from the lacrimal glands.
Thank you very much.
Thank you very much.
Thank you. Thank you.
Now may I invite Dr. Anchal Thakur. Our presentation is on a prospective study comparing different therapeutic regimens for acute adenoviral conjunctivitis.
Yeah, at the outset, I would like to thank AIOS for giving me this opportunity. So my topic is prospective randomized study comparing different therapeutic regimens for acute adenoviral conjunctivitis. So this was a prospective randomized study including 65 patients with confirmed adenoviral conjunctivitis on RT-PCR. I'll go into the methods in the next slide, but just I want to highlight that we also did viral load estimation of these patients, and it was highly variable in every patient, all the groups. Thus, we could not establish a correlation of the viral loads with the treatment. So 65 patients have proven acute adenoviral conjunctivitis presenting to the cornea services within first 4 days of the onset of signs and symptoms, and the treatment was given for 7 days. So we had 4 groups. One was control group in which carbomer gel was given. In group 1, ganciclovir 0.15%, 5 times a day along with dexamethasone 4 times a day. Group 2, povidone iodine 1% along with dexamethasone. And group 3, the combination of both group and 1 and 2, like povidone iodine 1%, ganciclovir as well as dexamethasone. So we are proposing that the addition of dexamethasone early in the stage of acute adenoviral conjunctivitis will prevent the sequelae of long-term complications like subepithelial infiltrates and pseudomembrane, which actually have a very high incidence in patients with epidemic keratoconjunctivitis, which we see commonly in our clinics. So the results were that there were no difference in sex distribution among each group, and the male to female ratio was almost similar in all the 3 groups. 55% patients had history of visit to the hospital. Maximum number of patients, that is 55%, they presented at day 2 of the signs and symptoms. 56% had bilateral involvement, and 52% had history of contact with a patient of red eye. 20% patients had history of lymphadenopathy, and all the patients in the control group, they were symptomatic at day 7. Whereas in group 3, that is patients receiving ganciclovir, dexa and povidone, minimal patients were symptomatic. Just showing in a tabulated form, when we compare group 1, 2 and 3, the group 3 patients, they had minimal foreign body sensation, lid edema and hyperemia, which was statistically significant from group 1 and 2. Although control group, maximum number of patients, they were symptomatic at day 7. Coming to the incidence of pseudomembranes and subepithelial infiltrates, comparing the group 1, 2 and 3, there was no statistically significant difference. But the control group, out of 20 patients, all the patients had subepithelial infiltrates. This may be likely because they were hospital acquired, or they may be a subtype of epidemic keratoconjunctivitis in which the corneal infiltrates are more common. Pseudomembrane was common in almost all the group, and the difference was not statistically significant. Just to go back on the literature, what is the role of povidone iodine in the treatment of acute conjunctivitis? From the previous studies, we know that povidone iodine does decrease the symptoms as well as signs, as well as the duration of conjunctivitis treatment. But there are 2 large studies, one was published in AGO in 2018, where they had 144 adeno-positive patients, and they had a multicentric randomized trial in which they divided the group into 3 groups: povidone iodine, povidone plus dexa, and a carbomer. And they have shown that povidone plus dexa, the patients had clinical resolution and a better adenoviral eradication rate on culture. Another study was a rapid study, which is reducing patient load in infectious disease in adenoviral conjunctivitis, and they also showed that 5% povidone iodine as a single treatment was safe and well tolerated in these patients. For ganciclovir, there are no many population, less number of patients are there for ganciclovir, and they have shown not confirmatory evidence for a significant difference in decreasing the adenoviral load in acute conjunctivitis. Thus, to conclude, ganciclovir and povidone, along with topical dexa, performed significantly better in terms of signs and symptoms compared to all the groups at day 7. And this treatment regimen significantly reduced the severity of signs and symptoms in acute adenoviral conjunctivitis. 100% of patients developed subepithelial infiltrates in the control group. Group 2 and 3 demonstrated better outcomes regarding the incidence and severity of SCIs as compared to group 1, but the difference was not significant. Also, the addition of dexamethasone was safe and significantly effective in decreasing the incidence of SCIs, and none of the patients reported any side effects of topical povidone iodine. Thank you.
The topical dexamethasone which you are using is 0.1%, so which is significantly lower than what we normally use for steroids treatment. So that could be a reason why the infections or the corneal melting is less in these cases.
Yes, of course. When we give steroids early in the course of treatment, the signs and symptoms are less. They have less redness, pain. But the idea was if we give only steroids without any antiviral cover, it is shown to the people shed virus. Shedding of the viral load increases if we give steroids alone. So we need to cover it with an antiviral agents from the start.
So the combination and the low dose steroid has
yes, has worked better. So we have changed our protocol to give, now we are giving routinely antiviral along with steroid from the day 1, because we are seeing a lot of SCIs. And now the incidence of SCIs has actually decreased after we started this regimen.
Is there any role of ganciclovir or adenovirus?
Yes, ma'am. Ganciclovir does work on adenovirals. It kills the intracellular viral replication, although povidone acts extracellularly.
Actually, nowadays povidone iodine is advisable.
Yes, but povidone doesn't go inside the cell and kills the virus.
Addition of steroid is depending upon the epidemic. Sometimes it may help, sometimes it may aggravate the disease. If pseudomembranes are there, and in those cases we can add. Otherwise, it may increase the replication of a virus.
Yes, ma'am. Studies have shown that they increase if given alone. So that is why we combined with.
And what about the risk of secondary bacterial infection? Did you cover it with any antibiotic as well?
Yeah, because dexamethasone was not available, so we combined moxifloxacin and dexa combination.
So effectively used a combination.
Yes,
and
in all the groups.
And how long the treatment would be, like how long did you administer?
We gave it for 7 days, and depending
Okay.
on the incidence of subepithelial infiltrates or pseudomembranes, we changed
Because
the
they are
quantification.
actually they are pretty recalcitrant, you know, they keep on recurring. So did you also consider adding an immunosuppressant, topical immunosuppressant like cyclosporine?
Yeah, later if they get recurrent SCIs, we do add cyclosporine or tacrolimus.
Because invariably they do recur. And so maybe yes, in initial stages we
But
can.
we have actually seen a lesser incidence after adding.
So when do you stop ganciclovir?
At day 7.
And povidone iodine?
Both at day 7.
Okay, and you continue with the combination?
Dexa, if there are infiltrates then. Then we can stop Dexa
because
also.
Because infiltrates typically they occur after episode of conjunctivitis, like typically 7 to 10 days, 7th day onwards.
Yeah.
So,
Thank you.
okay, thank you.
May I invite Dr. Anjali? Meibomian gland dysfunction and dry eye disease in mucous membrane pemphigoid.
Hello, good morning all. I shall be discussing the case series data of objective evaluation of meibomian gland dysfunction and dry eye disease in mucous membrane pemphigoid patients, which I did during my post-graduation in PG Amar Chandigarh. So as we know, mucous membrane pemphigoid is an immune-mediated systemic disease which affects females more commonly than males. It usually presents in 6 to 7 decades of life and affects the mucosal surface of the body like eyes, nose, mouth, upper respiratory, anogenital and gastrointestinal tract. It results in formation of subepithelial blisters which rupture and heal by fibrosis. So ocular MMP manifests as a chronic progressive cicatrizing conjunctivitis which has a risk of vision loss if left untreated, and it is quite common in MMP patients. Up to 80% of the MMP patients show ocular involvement. It ranges from dry eye disease to corneal ulceration, vascularization, keratinization of the ocular surface to symblepharon and ankyloblepharon. So the objective of our study was to evaluate the dry eye status in these patients and to find out if there are any early changes in the meibomian glands on meibography. So ours was an observational cross-sectional study done for 15 months in which we divided the patients into 3 groups. First group included patients with obvious ocular complaints which were being treated in the Department of Ophthalmology, and the second group had systemic mucous membrane pemphigoid without any frank ocular complaints. They were being treated in the Department of Dermatology, and group 3 had control patients which were age matched for both the groups. So all those patients which gave consent were known cases of MMP, aged more than 12 years, and were under treatment and had quiescence for at least 3 months were included. And all those which had Foster stage 4, previous eyelid surgery, contact lens use, radiotherapy, or history of use of isotretinoin, anti-androgens, hormonal therapies, oral contraceptive pills, and those which were pregnant and lactating were excluded. So slit lamp biomicroscopy was done for all the patients to evaluate the lid margin, meibomian gland orifice and the ocular surface, followed by ocular surface disease index scoring to evaluate the dry eye related complaints in these patients, and a dry eye workup which included tear film breakup time, ocular surface staining, Schirmer test, and we calculated lid margin abnormality score and a MEBO score for all the patients. MEBO score tells about the expressibility and about the quality of mebum expressed both. And mebography was performed, and this is the representative image of the mebography image that we get after the lippy view. And we used images software to calculate the area, total lid area, and the B image shows the area of meibomian gland loss. To calculate the dropout area, we divided the area of loss with the total lid area multiplied by 100, and we graded as grade 1, 2 and 3. 1 included those having meibomian gland loss less than 1/3 of the total lid area, grade 2 had 1/3 to 2/3, and grade 3 had loss more than 2/3 of the total lid area. So all the variables were described at mean and standard deviation, and ANOVA was performed to examine the significant difference between the three groups. Pearson correlation test was used to measure the strength and direction of the relation between the dry eye parameters. A total of 123 eyes were enrolled, and 5 eyes in the ocular MMP group were excluded because they had stage 4 disease. As we can see, the OSDI scores in ocular MMP group were significantly higher, which was confirmed on ANOVA test and the post hoc analysis, which suggests a higher dry eye related complaints in these patients. Also, the Sharma scores in both ocular and non-ocular MMP patients were lower. That showed significant dry eye disease in MMP patients as compared to the control. Also, both the non-ocular and ocular MMP patients had lower T-BUT values, suggesting a evaporative dry eye disease in these patients, and a significantly higher lid margin abnormality score in ocular MMP patient as compared to the age-matched control, which is further compounding the tear film instability and dry eye-related complaints in these patients. BIBO scores again were higher in the ocular MMP group as compared to both the groups, and meibomian gland dropout area were significantly higher in both ocular and non-ocular MMP patients as compared to the control group. The severity of MGDA loss was also higher. 64% in
Time is over.
So 64% of the patients in ocular MMP group had moderately severe MGDA loss, and 43% had in the non-ocular MMP group. So the importance of our study was, it was the first study to demonstrate the MG dropout area in MMP patients, and it outlines the potential damage to meibomian glands in these patients, and need to early diagnosis and appropriate disease management of these patients. Thank you.
Thank you. Yeah, I would like now like to invite Dr. Praful.
Good morning, respected judges and delegates present here. So I'll be presenting my study on measurement of intracorneal concentration of commonly used antifungal drug and their correlation with minimum inhibitory concentration in non-healing fungal keratitis. So what was the rationale for this study? You know, fungal keratitis normally carries a poor prognosis compared to bacterial, and one of the factors that has been implicated is poor penetration of the drugs. But if you go through the literature, hardly there are few experimental studies that actually evaluated the intracorneal penetration. So what we did in the study is we tried to explore whether we can use LCMS or liquid chromatography mass spectrometry to evaluate the corneal concentration of commonly used antifungal drugs, and to compare that with MIC to know whether they are crossing the MIC level of those particular organisms. So that was the purpose of this study, to determine the corneal concentration of natamycin and voriconazole and compare that with MIC 90 of the microorganism. So we did this at RP Center along with our Department of Pharmacology and Microbiology. It was a prospective observational because it was largely a laboratory based study. So we included all patients of fungal keratitis which were on medical management but not showing any response to the medical management. We excluded cases which had either perforated or thinning, severe thinning was there, or ulcer which has reached the limbus, or ulcer with systemic diseases that could hamper the estimation of drug measurement in the cornea. So we excluded these patients. This is the flow chart of how we did the study. So the host, all these recalcitrant fungal keratitis patients, they underwent therapeutic penetrating keratoplasty. So the sample was divided into two halves. One half we stored at -80 and sent to pharmacology lab for analysis of the drug concentration. The second was sent to microbiology to do the culture and MIC estimation. So MIC estimation as well as intracorneal was done. So intracorneal concentration was done by UCMS. This is the brief method. I'm not going to the details of this. For MIC level, we use this E-strip test, and you can see the zone of inhibition intersecting the with E-strip that was taken as the MIC value. So statistical analysis, continuous data were analyzed using t-test and non-parametric tests like Mann-Whitney was used for non-normal or non-continuous data, and Spearman correlation analysis was done to look for the association between various factors. These were the baseline parameters. Mean age was 48 years. Most of the patients were male. Most corneal ulcer, most of the ulcer was 74, as you can see, central, and most of the corneal ulcer were either mid-stroma or deeper involvement like normal fungal keratitis. And ulcer grade was, as per Harrison stage, it was 67%. Mean ulcer area was 24.33 in overall in study. So baseline characteristic, these are the two parameters important we evaluated. How much duration the patients were receiving antifungal drugs. It was 14 on the median was 14 days for voriconazole and the 17 for natamycin. And frequency, so voriconazole it was almost 9.7 per day, and for natamycin 9.6 per day. Aspergillosis was the most commonly identified organism, 42%, followed by Fusarium, Cladosporium, then Alternaria. And total 43 patients were enrolled, and the mean concentration for voriconazole was 0.08, for natamycin it was 0.01. So these were the various factors that we correlated with the intracorneal concentration, like age, gender, duration of treatment, frequency of treatment, and interval from the last dose, as well as ulcer area and infiltrate area and ulcer location. So these were the result of Spearman analysis. As you can see, none of the factors were seemingly to be correlating with your intracorneal concentration. This is organism wise, I'm not going to the details of that, but it was a last study. We had a lot of data, that few of the data that I would like to share here. In only 9.5% of the cases, the intracorneal voriconazole concentration was above the MIC 90, while that was 33% for natamycin. So if you correlate with the outcome of MUD study, where they found natamycin is better than voriconazole, this could be a factor, because penetration of natamycin theoretically is poorer. However, when you go for the real life scenario, that may be better than voriconazole. The second concerning factor was, if you can see the last 2 points, in 52% of the patient, the MIC of natamycin was beyond the upper limit possible with the strip test, and in 23% voriconazole, it was again crossing the upper limit. So this is a concerning factor, because this indirectly points towards, although other technical factor, if you exclude, it could be a factor for rising resistance of antifungal drugs. And if you go through the recent study by Prajna et al., where they found that in India, the incidence of resistance against these drugs is rising by 1.08 factor yearly. So that is a concerning factor for us also. Now with this study, what we learned that LCMS technique, yes, it is feasible to do to measure intracorneal concentration using this technique. And susceptibility testing, if you have a fungal keratitis not responding, please go ahead with the susceptibility testing. So limitation was MIC never correlates directly with your clinical outcome. That is one limitation. Second, LCMS was a new technique. It needs more standardization for intracorneal concentration estimation. And one other factor, E-strip test is not a standard method. Broth microdilution is the best technique for sensitivity testing, and that we couldn't do because of logistical issues. Thank you so much. I'll conclude here. Thank you so much for your kind attention.
Excellent presentation, Dr. Prafulla. Just 2 points I would like to add or ask you is that did your ulcers who were resistant to therapy, did you rule out intrastromal injections as well? Like, did they receive intrastromal, because then the MIC may vary?
So in all these patients, we excluded those patients who had received oral antifungal as well as intrastromal, because that would have a bias effect, confounding factor on the intracorneal concentration.
But so then how did you, what was the inclusion criteria?
Inclusion criteria, as I shown, all those
of
patients.
Labeling them as non-responsive. Because
so all those patients on natamycin and voriconazole for more than 14 days. At RP center, what we do, we start with natamycin. If there is no response within 1 week, we add on voriconazole to that topical. Within 14 days, if there is no response, then we move on to intrastromal therapy or therapeutic graft. So here what we did in all these for patients after 14 days, we went out with the therapeutic penetrating keratoplasty.
Okay. Thank you. And another confounding factor could be the compliance issue. I mean, if the patients were not admitted under your care,
so for therapeutic, patients were admitted, but compliance, yes, that could be a factor. That's why we did that Spearman analysis to check for whether frequency of drug instillation is correlating with your intracorneal concentration.
Yes. Thank you.
Thank you.
Dr. Apeksha? Dr. Preeti is there? Dr. Preeti?
Do we have Dr. Preeti Zingade? Dr. Apeksha Kataria?
Dr. Poonam Singh is not there, no? Dr. Nikita Shah?
Good morning, everyone. No financial disclosures enclosed. My topic for today would be pharmacological modulation of autophagy and its therapeutic potential in pathogenesis of pterygium. So what we know is pterygium is a fibrovascular growth, and there are multiple etiologies to it. What we don't know is why is the recurrence happening even though we apply all the surgical techniques. The prevalence of recurrence ranges from 5 to 69%. So what is autophagy? Autophagy is, in simple words, cell eating cell to maintain homeostasis. What is the aim of our study? To investigate the role of autophagy regulation and its therapeutic applications for clinical management of pterygium. The first research question would be, does dysregulated autophagy has a role in pathogenesis of pterygium? So the methodology that we used were, we had taken 20 control conjunctival tissues which were obtained from cadaveric eye and 20 pterygium tissues which were obtained post-surgery. These underwent protein separation using Western blotting and immunofluorescence, and expression levels of autophagy-related proteins were analyzed. We did an in vitro study where 20 pterygium tissues were obtained post-pterygium, which were taken to the lab in 3 different Eppendorf tubes as subconjunctiva, body and head, and different autophagy-related proteins were analyzed. So what are autophagy proteins? Proteins that are involved in the formation of autophagolysosome to cause autophagy. So the results that we obtained were, majority of the autophagy proteins were seen showing less expression in the pterygium tissues as compared to the control conjunctiva. The immunofluorescence microscopy of control conjunctiva and whole pterygium shows that the autophagy protein LC3B shows less expression in the pterygium tissues compared to the control conjunctiva. So the second question would be, is there a correlation between autophagy activity and fibrovascular density in different regions of pterygium? So differential expression, in our study, we saw that the subconjunctival part had the least amount of autophagy proteins as compared to the body, as compared to the head. So can it be related? The third research question would be, can autophagy modulating mechanisms halt the progression of pterygium and prevents its recurrence? So this is immunofluorescence study with LC3B autophagosomes, where the untreated and the treated eye with trehalose, which is an autophagy modulating drug, showed that the nucleus part, and the nucleus part is the blue part and the red part is the autophagy related protein part, where it shows the increased expression in the sample where we put an autophagy inducer, which was the trehalose. So coming to the discussion, the established role of trehalose in the induction of autophagy is already studied in the dry eye disease, but we haven't studied it in pterygium tissues. The ongoing study for our presentation would be role of autophagy modulating drugs in preventing recurrence and halting the progression when used in early stages in patients with pterygium. So what we already knew was, pterygium is a fibrovascular growth of conjunctival tissue. there is an increase in angiogenesis, fibrogenesis, and inflammation that leads to different forms of pterygium in different patients, and we don't know what the particular etiology in particular patient is. The treatment modalities as far as surgical excision. What this study adds is, based on the in vitro study that we did, we cultured the conjunctiva and the pterygium fibroblast tissues, and we saw that the autophagy modulating drugs might prevent the recurrence of the pterygium, and there are differential expression of autophagy proteins at different parts as the subconjunctiva, body, and head, and it can be helpful in halting the progression while pterygium is at an early stage. Thank you.
Yeah, thank you, Dr. Apeksha.
Thank you, ma'am.
I would just like to ask you one thing. Any reason you could find out that how the autophagy is triggered in subconjunctival tissue, especially the nasal limbus?
So we also did was the control conjunctivas was exposed to UV light for 10 seconds and for 20 seconds. So the major cause that is known for pterygium is the UVB induction. So for the first 10 seconds when we expose, there is an increase in autophagy as compared to when there is prolonged exposure to UV light, the autophagy proteins significantly come down after UVB exposure.
And its relation with the location of the pterygium, why it is more common in the nasal side rather than because the...
Yeah, so what is known is because the UV light falls, because of the nose it falls on the nasal and temporal part. So mainly the nasal part, so because of that the pterygium is more common around that. Thank you, ma'am.
Dr. Preeti?
Do we have Dr. Preeti Zangadi? Dr. Ashish Ahuja?
Three are absent, no? Three are absent. Dr. Preeti,
Dr. Poonam Singh?
Dr. Nisha.
4 are absent, no?
Dr. Poonam Singh?
Three absent. Three. Nikita,
ये तो absent है.
Ashish.
Dr. Nikita Shah absent.
Yes.